finally we get double contrast BE, and we'll talk about pathologies as well. This video assumes that you watched part 7 and that you're familiar with the routine for a single contrast BE. Everything that we're going to do on a single contrast BE, we're going to do on double contrast. So I'm not going to duplicate that. You're going to have to go back and watch, watch that other video. But we're going to add some things to it. Everything that you do PA, you can do AP. Everything that you do AP, you can do PA. Anytime you need an angulation or the patient's body to move, you can use angulation of the x-ray tube to compensate for either the patient's anatomy or their inability to position themselves. So we're not going to rehash all the AP obliques and all that, but we are going to talk about what we see in those specific to a double contrast enema as opposed to the opposite. So we're going to do APs, AP obliques, PAs, PA obliques, and some other things as well. So we're going to talk about the different methods. There's 2 different types. We've already looked at one type, but the Wellen method we kind of need to talk about just a little bit. So your single stage system is what you're going to be working with most likely. In single stage system, you put the barium in the patient and you put the air contrast through the entire single apparatus. With the Wellen method, we do something a little bit different. And full disclosure, I've never done this a single time in my career. But what you would do with the Wellen method is you would introduce the barium all the way up to the splenic flexure, remove the enema tip, have the patient go to the restroom, and then put the enema tip back in or an enema tip back in so that you can introduce air and have the patient roll around into different positions. So they say that the Wellen method is good for small polyps, small pathologies. I think that probably colonoscopy has done a good enough job that we don't really do the Wellen method anymore, but it is, as far as I can tell, still registry testable. So what we have with this image here is it's double contrast. We can tell that because we can see a clear difference between the air and the barium. Remember, every time we do a double contrast, we're looking for the mucosal lining, and this is a good image to show how that plays a part here. So you put barium inside the patient, you roll them around, then you introduce air. You roll them around so that you can get the barium throughout the colon and through all portions of the colon and all sides of the colon. And then you introduce the air to inflate the bowel. And notice you can see like the haustral markings really well on this. You can see everything. So it's coated with barium, but the air separates it, so it's not a solid mass like what we see down here. That solid mass, we wouldn't be able to see those. So likewise, if one of these was some sort of pathology and we were completely filled with barium, you wouldn't be able to see it unless you were looking at it kind of on a profile and it was sticking out like that. But if we had these, and we do, have those lines going through the barium, you just can't see them because the barium's too hard to penetrate. So double contrast has its place, and its place is to show that mucosal lining very well. All right, so again, we're going to do all the APs that we talked about before, but we're going to rotate the patient around. We're going to have them in PA projections for obliques, and we're also going to do both bilateral decubitus. So it's double contrast, and again, this shows us what it is that we're looking, what we can see with a double contrast, what we can't see with a single contrast. In this case, what we've got is we'd be able to see this in a single contrast, but that would be a diverticula. I would suspect that's a diverticula there as well, but if this colon was completely filled, we wouldn't be able to visualize those. So a diverticulum is just outpouching again from the inside of the alimentary tract. In this case, it's in the colon. Just more of the same. That was AP oblique. We don't really need that. So PA obliques. So I'm going to try to make this very simple. I'm going to try to shorten it quite a bit. If you recall from the AP obliques, this is a high voltage cable from an imaging system. But if you recall from AP obliques, what we saw was the flexure on the elevated side. So if you were looking down from the ceiling at me, laying flat on my back, or at this patient laying flat on its back, and I were to rotate what would be the patient's left-hand side towards me, and the right-hand side will be elevated, then in AP obliques, if you recall, we see the elevated side. So in this case, what we would see is a hepatic flexure. In a RPO, we would see the splenic flexure. So if we flip this around, I already had it bent, so it was easier just to turn the whole thing around. But if we flip the patient around, then what we see is the exact opposite. So this patient would be in a LAO position. So what we're going to see in a LAO position is a hepatic flexure. And in the RAO position, remember your difference between position and projection. But in your RAO position, then what we're going to see is the splenic flexure. So two things that you're going to have to look for on those obliques is where is the air and where is the contrast. PA obliques, for the most part, the air is going to be on the elevated side, so it's going to be on the opposite side of the flexure that you would normally see. So think gravity and think about the difference between the weight of air and the weight of barium, right? So your PA obliques, you're going to be seeing contrast in the side that's closest to the image receptor. On your AP obliques, you're going to see air. So between the LPO and the RAO position, those two correspond, right? So LPO, we see the elevated side, we see the hepatic flexure. RAO, we see the side that's closest to the image receptor, and we see the hepatic flexure there as well. So those two go together. But in the PA obliques, we're going to see barium in the hepatic flexure. In the LPO, we're going to see air in the hepatic flexure. So reverse all that for the splenic flexure. Still 30 to 35 degree obliques, RAO or LAO, and just know your anatomy for each one of those. I'll go through this kind of slowly. Okay, so I put an asterisk here because do you really need to see the entire colon? The answer is you'd like to, but no, not necessarily. So what are you looking for specifically with the PA obliques? That's going to be side closest to the image receptor. So in the RAO position, you're going to be looking for the right colic flexure. So what you want to do in some cases, I'll show you some examples of this in a second, but what you might want to do is position a little bit above the crest. Your central ray positioning is going to be 1 to 2 inches lateral to midline, just like on the AP. Although you've got a little bit more of a visual in this case, just go 1 to 2 inches lateral towards the elevated side to be lateral to the spine. So you got a visual there. You can palpate, but you've also got a visual there as well. So it makes it a little bit easier. But again, back to this slide and this asterisk. What do I mean by maybe, and why do I put this here? So what are you looking for on the obliques? On the RAO, you're looking for the right colic flexure. If you have a hypersthenic patient who's tall, then you might intentionally off-center a little bit high, right? Because your flexures are at the top, but also you might want to go further than that 1 to 2 inches if the patient's hypersthenic. What you don't want to miss is the right colic flexure. It's the whole purpose for doing this particular position. So if you clip the right colic flexure, if you don't include it all, you're looking at a repeat. So we want evidence proper collimation, your right colic flexure open, Your ascending colon, your cecum, and your sigmoid colon should also be pretty well visualized. So again, 35 to 45 degree oblique. And this demonstrates exactly what I was talking about. So here we have the obviously open right colic flexure, hepatic flexure. Remember, the hepatic flexure is always going to be lower than the splenic flexure because the liver's so big. And whoever, he or she, whatever, included the entire splenic flexure. Wasn't absolutely necessary. It probably could have positioned at the iliac crest and gotten the right hepatic or the right colic flexure, the hepatic flexure. If they had not, though, then this would be a repeat. So it might be a good idea, since you don't know exactly where it's going to be, it might be a good idea to position 1 to 2 inches above the iliac crest to give yourself a little grace. They did not do that here. It looks like they positioned at or possibly a little bit below the iliac crest, and you don't see the top of either flexure. This, in my book, is absolutely a repeat. Sometimes things seem a little bit counterintuitive. So this, if you notice, is marked RAO position, which means that the right colic flexure should be closest to the image receptor, and it should be full of contrast. Because this thing down here, which you don't see except for in textbooks anymore, or if the college has a library of old x-ray films, you just don't see this anymore. But this is where we used to put the patient's name and their information, their date of birth and things like that. So this being on this side of the patient indicates to me that this truly was an RAO position. But if it's an RAO position, based on what I was mentioning before, the barium should theoretically be in the right hepatic flexure, or the hepatic flexure, the right colic flexure, and air should be over here in the splenic flexure. Sometimes things just don't match up. Evidence suggests this is an RAO, even though the image doesn't necessarily look like it. Keep in mind that your transverse colon is also anterior, so this is coming back posterior just a little bit, so the difference in the angulation at that flexure could account for what we're seeing here and why the hepatic flexure is not full. So we want to see the entire colon as best case scenario. But the reason I put this asterisk here is to explain this. What you're looking for on the obliques is your flexure. All right, so if you off-center just a little bit, if you err, in your positioning, err towards what is most likely to show you the anatomy that you need to see. In other words, in this case, what you need to see is the top of the colon. So if you misposition high, right? So if you go couple of inches above the iliac crest, position the image receptor maybe closer to like what you would do for an upright abdomen, then you're probably going to, you should include all of the required anatomy, and what you might not include is anatomy all the way at the bottom of the colon. But what you're looking for primarily is that left, in this case, PAO oblique LAO is the left colic flexure. So that one's probably more important than the hepatic flexure to intentionally position high. That left colic flexure can be quite high. Also, if you go back to the basic positioning, we've got 1 to 2 inches lateral to midline, but if you have a hypersthenic patient, a really big patient, what you might want to do is might want to intentionally off-center further towards the elevated side. And the reason for that is, again, because what you're looking for is a flexure. So if you don't include all of the anatomy, that's okay. What we want to see primarily would be those flexures. And again, that's what you're seeing here is the difference in what appears to be an intentional off-centering to make sure they get the flexures, as opposed to this one over here. They position at the iliac crest, or maybe even slightly below it. That looks like femoral head there. And neither one of the flexures are on that image. So to me, this is a completely useless image. And even though this is not textbook positioning, it shows the anatomy that we want to see. And because of that, I would pass this and I would not pass that. So just basic positioning. Sometimes also keep in mind that your colon, all your patients are not going to be the same, and your colon, in this case, what we've got is a very vertical transverse colon. This thing is just kind of a mess. The positioning wise, and as far as image integrity goes, this is a good image because we see the open flexure. And it's a solid column image as well, but we see the open flexure. And since we see the open flexure, then it's a good image. You're just not going to be able to desuperimpose all this stuff in here. So just more images. This just kind of walks through what I was talking about before. Carries it out a little bit further. PA projection. What you're going to have is, because of barium, what you're going to have is you're going to have air in the ascending and descending colon, but the transverse colon should have more barium in it. I'm not going to say it's filled, but it should have more barium in it. AP projection, transverse colon is going to be further away from the image receptor, so the barium is going to be in the ascending and descending colons, and with the AP, it's going to be we're going to have air in the transverse colon. More of the same. So now we get to truly some new images, and that would be your left and right lateral decubitus. So I'd mentioned this in the solid column BE, and that was to write down on a card what you're going to do. Right, so you do AP, RPO, LPO sigmoid if that's your routine, lateral, LAO, PA, RAO. And we'll get to a rectum. Your rectum is going to be the last image before the patient goes and evacuates their bowel. But before you get to that point, you've also got to rotate the patient another full revolution. And that is so that we can do a left or right lateral decubitus position. So what we're going to do is we're going to rotate the patient all the way up onto their side. You may have to build the patient up just a little bit because the divergence of the central ray may project the patient's anatomy into the table. So you might have to build the patient up a little bit, put them on a radiolucent support, or maybe some sheets. Better for radiolucent support. Doubled up sheets can show on the image a little bit more than what your sponges will. So your positioning is going to be just like KUB for both AP and PA. The difference here is going to be that the patient's going to be on their side, and you're going to utilize a horizontal central ray. So it looks like that. So let's assess this image just a little bit to make a point. On your decubitus, you're going to have to assess where the air will be and where the barium will be as well. And this is the next complicated thing on this image, not just where the air and the barium will be on your obliques, but also on your decubitus images as well. So taking a look at this image, what we see is we have this anatomy much higher than this anatomy. So what that would indicate to me is that this is a left lateral decubitus. The left side is closest to the floor. It's like the patient's laying on the left-hand side. We can also look at this thing right here. That's your right marker. So your decubitus images can be shot AP or PA. either one. I just recommend that you shoot from one side of the table, so naturally one is going to be PA and one is going to be AP. So what you've got then is you've got the splenic flexure and you've got the hepatic flexure, and the patient's laying on the left-hand side, and what we see is the lateral side of the descending colon is full of barium. The medial side of the descending colon is full of air. And then the medial side of the ascending colon is full of barium, and the lateral side of the ascending colon is full of air. This is my left hand right here. So left hand side is closest to the image receptor. So what we're going to see then is air on the, if this is the patient's left, again, that will be your splenic flexure, and your hepatic flexure is over here. So what we're going to see is we're going to see air on the lateral side of the ascending colon, and then we're going to see barium on the medial side of the ascending colon. And then we're going to see air on the medial side of the descending colon, and then we're going to see barium on the lateral side of the descending colon. So once we flip the patient over into right lateral, everything reverses. So this is my right hand side, so this is my ascending colon. So what I'm going to see is barium on the lateral side of the ascending colon, and I'm going to see air on the medial side of the ascending colon. And then I'm going to see barium on the medial side of the descending colon, and air on the lateral side of the descending colon. So again, that's kind of complicated, but it's easier to demonstrate to me to get it in your mind. It's a little bit easier to demonstrate than what it is to just recite it. So your left lateral decubitus position, you want everything. And you may be back to having to shoot 2 images for hypersthenic patients. So again, we'll look at this. Again, we've got the same situation here. We've got air in the medial side of the descending colon. We've got air in the lateral side of the ascending colon. We've got splenic flexure. We've got hepatic flexure. We can tell that this is left lateral because the right marker is on it pointing up. All right, so we've got barium in the lateral side of the descending colon. We've got barium in the medial side of the ascending colon. So I really recommend that, by this point you're probably a second semester student in your program at least, or if you cover all anatomy in a single semester, you have gotten more familiar with your classmates. Shift yourself in your chair if it helps while you're taking a test. Just kind of position yourself. So right lateral decubitus position, AP projection. We'll see everything. That's what you're looking at. So now we can tell that this is a right lateral because we've got a left marker up. That's indeed the left-hand side of the patient, unless the patient has a condition where their organs are reversed. Much higher than this, that would be splenic flexure, hepatic flexure. So I'm not going to walk through all the, barium and air thing again. All right, so we shot an AP axial. Now we can shoot a PA axial. So again, we're going to be looking at 30 to 40 degree caudal angulation, central ray at the level of the ASIS, and by the time it passes through at that pretty steep angulation, it'll pass through the rectosigmoid area. Even though I work in an area where we do the LPO sigmoid, I've never had a radiologist ask for an RAO sigmoid. Your mileage may vary. So just gonna kind of go through these. That's your PA axial. There's is your PA post-evac. Your post-evac, I've also never had a radiologist be specific that they wanted a PA post-evac. This would, again, be after you did your lateral rectum, and you would follow the hospital protocol in however they wanted to do that. If they wanted you to just shoot the lateral with patient rotated up on their side, cross table with patient prone, cross table with patient prone with the enema tip pulled out. All of that was explained in the previous video. At the beginning of every Merrill's chapter, there's a comprehensive list of pathologies you need to know. I'm just going to touch on these, and that is cancer, intussusception, which may be secondary to cancer, volvulus, which may also be a small intestine pathology, diverticulosis or diverticulitis. There's really no difference between the two except for this is an inflamed diverticulum. Colitis and appendicitis are the ones we're going to look at. Even though appendicitis isn't really a colonic issue, sometimes you'll see the appendix in retrograde filling of the colon. So you got to know all the anatomy from drawings, from descriptions, know when to use iodinated contrast, know the limitations of the iodinated contrast, and that is you can't do double contrast. Know the contraindications for iodinated contrast, and that unlike your injectable contrasts, the iodine may play a larger part. So know your patient's allergies. Know when to use barium and when not to use barium. Most of the time, if possible, you want to use barium, certainly for double contrast. But again, if a patient has suspected perforation, you don't want to use barium. So make sure you take a history. If the patient's passing a lot of blood, and if the patient knows that they've got a perforation, then that needs to be communicated to the radiologist. So know what types of air that we can use for air contrast PE, and that's basically room air would be one, and the other would be the CO2. Never use CO2. Know the benefits of air contrast. Again, that's going to show you your mucosal lining. Know the patient prep. NPO after midnight, some sort of cathartic laxatives, enema possible. Know all body positions, where the air is going to be and where the barium is going to be on each one of the exam types, and what specific anatomy is shown on each one. So neoplasm, a carcinoma, invades the lumen or the area within the bowel. All right, so what you get is this characteristic look, kind of like a napkin ring. So a linen napkin with a ring around it. You just got this area that's kind of scrunched down. It's also referred to sometimes as apple core lesion. And neither one of these truly look like an apple core, but sometimes you'll see one that looks identical. You could do a Google search and probably find one that looks just like an eaten apple. So that's cancer. Intussusception is where a portion of the bowel slides into another portion of the bowel, kind of what you're seeing on this diagram, and it gives us what we refer to as a coiled spring sign. So that's what that would be. In kids, that's idiopathic, meaning we don't know why it does it in kids. If we can get the patient to the hospital, and the enema can be not just diagnostic but therapeutic. So what they would do is they would flood this patient's bowel with contrast, and what would happen is that the more full it got, the more it would reduce that sliding. In adults, that's usually secondary to something else, like does the patient have cancer, or there's something else going on that would cause that to happen. So the danger in this is that because we've got blood vessels going all through this, and you've got the potential for pinching that blood supply off twice. It's kind of like taking a water hose and doubling it over and pinching it off. If that blood supply is compromised, then that portion of the bowel can die. It can become necrotic. So if they don't get that reduced, reduction just means, let's say for lack of a better word, fixing it. If we don't get that reduced, we don't get it stretched back out, then that portion of the bowel could die, and the patient's going to probably be wearing a colostomy bag for a while, and they're going to have their bowel resected. Volvulus means twisting. So what we get with that is a bird beak sign, and this is an image I pulled off of the internet, and it's fairly classic in appearance. It's not exactly like what I was hoping to find, but you can kind of see it. You can also see that because of the twisting, the patient's got a lot of gas, which would indicate a bowel obstruction. So volvulus is twisting. Intussusception is where you get one sliding into the other. You can't really reduce this. This patient's going to surgery. Diverticulosis just means presence of diverticulum, and then diverticulitis means that those things are indeed inflamed. So a lot of people have what we just refer to as tics, and where you've got a tic, it bulges out from the lumen of the bowel, as opposed to a polyp bulges inward. A polyps can be one of two types, precancerous or just not. So let's say this was not sticking out as a diverticulum, but it had the exact same shape and is poking inward. That would be a polyp. And if it's pedunculated, meaning that you've got a skinny stalk, that would be an indication of just a benign polyp. Your precancerous polyps tend to have a broader base to them, so they project inward, and instead of projecting in kind of like a bubble, they project inward more like a lump. Ulcerative colitis looks a lot like Crohn's disease does, except for in the large intestine. So what you get is this just kind of eaten away appearance. So if a patient has a history of bad stomach cramps and passing blood, that would be an indication the patient has ulcerative colitis. I'll talk just real briefly about evacuative proctogram. It's referred to as defogram. So what it is a functional study of the rectum and anus for all these clinical indications here. So what we're going to do then is kind of like a PE, but we're going to fill the patient up minimally. Probably not going to completely fill the bowel, but we're going to fill the patient up at least the distal portion of the bowel and watch as the patient defecates. A defogram is going to come with some specialized equipment. So it looks like somebody built this cabinet for this particular institution. I don't think this is something that they ordered from online. But it's got a commode seat on top of it so that the patient can sit. And you notice that the fluoro tower is standing upright, or the table's standing upright. So that would indicate the patient's going to be upright for the exam, as you're seeing here. So again, I've seen these built out of PVC. What I have never seen is this caulk gun set up here. Not real sure what that's all about. But you also notice that what we've got is a tubing, and we've got probably a catheter tip syringe here. I've never seen this particular setup either. We just always used enema bags. But if they're using a syringe, then that would indicate to you that the patient isn't going to be taking just a whole lot of barium. So we would, again, insert the tubing into the patient, fill them up just a little bit, and then see if they can defecate properly. So this concludes GI studies. Next up will be GU and biliary. If you found this helpful, like, subscribe, share, all the stuff. Thanks.